Most of this I got from CKS, which is like clinical knowledge summaries. So they're dead good for anything. Like if you like don't know anything about it, you should just Google like CKS headaches. And it comes up with linked guidelines, and it's all the like nice guidelines. So I'm sure you're all very competent taking a headache history, but I thought we'd talk about what are some red flags for headaches. So what might concern you in a headache history?
A thunderclap headache.
Yeah, good, Alex. And what would that potentially indicate? Oh,
Subarachnoid hemorrhage.
yeah, good. What else?
We've got some people in the chat saying worst headache of my life, or a headache on waking up in the morning.
Yeah, good. So worst headache of my life, subarachnoid hemorrhage. Headache and waking up in the morning, what's that from?
Raised ICP.
Yeah, good. And what are some dangerous causes? I guess all raised ICP is dangerous. What are some causes of raised ICP?
Tumor.
Yeah, good. Anything else?
We've got someone else in the chat saying brain tumor as well.
Perfect. These are all along the right line. Anything else about the patient specifically? So what kind of a patient would you be worried about if they had a headache?
Anyone who's frail, had a fall.
Yeah, good. So that might be what kind of thing?
Could be either them having a fall because they had a stroke, or them having a hemorrhage as a result of the fall.
Yeah, good. So like a bleed. Yeah, so like I guess also new confusion is quite worrying in a headache. So I will go through some of the headache red flags. So these are all from CKS. So about the patient, if they're over 50 and they've got a new headache, that should ring alarm bells. If they're pregnant, so what would a headache in a pregnant person, why is that dangerous? What's a common complications? So they might present with headache, vision changes, swelling, high blood pressure.
Yeah, someone else is saying it in the chat.
Yeah, it's a preeclampsia, perfect. And a past medical history of malignancy. So that's obviously really soon. If they've had breast cancer 5-10 years ago and they present with a headache, that should ring alarm bells. And compromised immunity, which is something I would never have thought of, but that can be like CMV, retinitis and stuff, which is what Freddie Mercury died of. Interesting fact, or like was part of what Freddie Mercury died with. So then about the headache. So someone mentioned like new and severe, like thunderclap, worst headache of my life. If it's progressing, that's a bit worrying. So I think what I was thinking earlier, to be honest, anything in medicine that's getting worse should make you a bit nervous. So that's like one of the things. And then if it's associated with infective features, so stuff like pyrexia, meningism, papilledema. So has everyone tried to look in someone's eyes at GP? Has anyone ever been able to see anything? Because I can never I'm not very good at someone could tell me they have papilledema and I'd be like, yeah, sure. So it's obviously good to practice. Most GPs I've ever met have been like, I can't see much. You can have a quick glance. And if their eyes have really bad papilledema, but if you're worried, it's worth referring anyway. Other signs of ICP, raised ICP, visual disturbance and vomiting. So what can cause headaches? So we can group these headaches into 2 different categories. Can anyone think of them?
Secondary and primary, is it?
Yeah, perfect. So what's a primary headache?
It's either migraine, tension, as someone's saying.
Yeah, good.
Trigeminal neuralgia.
Yeah. So it's stuff that's like, I guess, it's not like another pathology. So what's a secondary headache? What's an example of a secondary headache?
Just to quickly jump in, for primary headaches, someone else said cluster.
Yeah.
And for secondary, we've got medications and hypertension headache.
Perfect. Yeah, good. So these are like all things that are causing a headache. Yeah. So primary headaches, generally, you don't need to be too worried about. Secondary headaches are due to another cause, which is what might be the dangerous thing. Does that make sense? So in terms of it's saying answers and OSCEs and stuff, if you put like any form of organization in, they think you know what you're talking about. So that's what I've started doing. So honestly, even if you don't know anything, as long as you're like go through a surgical sieve, or you think if you're talking about a cancer, if you're like, oh, well, you know, in the early stages it could present with this, in the later stages it's all playing a game, and it just shows you know what you're talking about, or at least you pretend what you're talking about. Does that make sense? So some causes of secondary headaches. Can someone tell me some causes of secondary headaches? I think I can see the chat now. So you can put it in the chat, or you can shout out, up to you. So what nasty things cause headaches, basically? So someone's already said like cancers. Good. What else? Yeah, perfect. Really good. Yeah.
So just for people watching this back later that may not be able to see the chat.
Oh, sorry.
Brain tumor and abscess, just as a thought.
So hemorrhage, perfect. So have people heard of the surgical sieve? Maybe, yeah. People always mention it on Wolverines. I never knew what it was until like last year. Okay, so I use vitamin D, E, F, or vitamin C, D, E, F. So can anyone think of any vascular causes for a headache? So Alex has mentioned hemorrhage. Any others?
Giant cell arteritis.
Yeah, so that's like autoimmune, but yeah, definitely vascular. AV malformations, rupture and bleeding, really good. Has anyone heard of sinus vein? No, what's it called? Venous sinus thrombosis, which I hadn't heard of before, like last year.
Is it cavernous sinus thrombosis?
Oh, cavernous sinus. Yeah. So sorry. Yeah. So does that make sense? So that effectively you get blood build up in the head. What else? Someone mentioned hypertension already. Okay. Infective causes of a headache. Meningitis, good. That's like your main one you want to think about. And encephalitis. So even in OSCEs, you can see that the person in front of you doesn't have meningitis. Because if they have meningitis, they probably wouldn't be in like a consultation with a medical student. But it's really important to always ask about like neck stiffness, and like any rashes, any photophobia, stuff like that. Traumatic, someone's already mentioned subarachnoids and subdurals. Any autoimmune causes? So there's something you can always say, which is an autoimmune cause of almost everything. It's always on house.
Silly.
I didn't hear that. Yeah, SLE, good, yeah. So you can say lupus, but it causes lots of different things. And Behçet's as well, which is like the one that causes like genital ulceration and stuff. I'll quickly run through the other ones. Oh, idiopathic causes, or like inflammatory. Anyone? So like temporal arteritis, other vasculitises, and also idiopathic intracranial hypertension. So we can run through these really quickly. Chiari malformation, so that's just like a congenital malformation. There's lots of other bits. Does that make sense? So lots of things can cause a headache, and you want to rule these out. So if someone's got any red flags, you're thinking about these things. So primary headaches. So someone already mentioned migraines. What are the other types of primary headaches we could think of? Oh, whoops, I already put one up. Okay. Any others?
So we've got cluster headaches and trigeminal neuralgia.
Yeah, perfect. And the only other one I would add, it would be like medication overuse headaches. So I've not done much on trigeminal neuralgia because that's like, so there's this distinction between headaches and facial pain, which is really blurred. So they often teach them together. But yeah, you need to like consider those definitely. So, and then these are like some quite cool ones or quite interesting ones that I've just done a little bit on. So tension headaches present, oh, whoops. Okay, how do tension headaches present? Let's go back. Okay, I'll just tell you. So put chili peppers next to like important stuff. So they're often bilateral, stress, caffeine, alcohol. The class is chronic if you get more than 15 a month. And it's like a clinical diagnosis. So how do you, what are the lifestyle things that you can do for headaches?
We've got more sleep.
Yeah, good. Anything else?
Hydration, stopping caffeine consumption.
Yeah, all really good stuff. What kind of foods are not good for headaches?
Chocolate.
Yeah, so it's all like nice things. So it's like chocolate, coffee, red wine, stuff like that. So another thing I tried to do in OSCEs is like always talk about something lifestyle related first, because then it shows that you're not just like considering pharmacological management. And then you can give any painkiller you want really, as long as you're not giving like opioids. So nice recommend NSAIDs or paracetamol or aspirin. Obviously, if they've got renal impairment, you're not going to give them loads and loads of NSAIDs. And nice recommend acupuncture, which I was a bit surprised by, but it's like 8 to 10 courses over 5 to 6 weeks or something like that. So yeah, a bit of like alternative medicine. So a migraine. So these are the things that I thought were like important. So past medicine always has a question on this. In kids, they're sometimes bilateral and they get like GI symptoms more often. So when we get them more than men, what's the link between the combined pill and migraines?
Take the combined pill if you have migraines with aura because you're at increased risk of stroke.
Yeah, good. And then even if you have migraines without aura, I think it's still UK MEC3, which basically means that like you shouldn't really be taking it unless you have to. So these are like obviously triggered by like the same sort of nice things. Have people heard of hemiplegic migraines? Oh, sorry. So these are migraines that like present like stroke sometimes. So they're like a stroke mimic, which is quite an interesting thing. So these people tend to go to A&E the first time they get one, and they get like a full stroke workup. And actually, it's just like a weird manifestation of the migraine. So they get like a hemiplegia. So it's a clinical diagnosis from the International Headache Society, which is the criteria on the side. You don't need to learn this, I don't think, but it's all the sort of thing that you'd expect a migraine to be. It's unilateral, pulsatile. And a good thing to ask in a headache history is like, what do you do when you get a headache? Because that really gives you like a good clue as to what the like cause is. So we talked about the management is just, if you need to give something, you give an orotriptan and an NSAID, or an orotriptan and paracetamol. And then prophylaxis is topiramate and propranolol. So there's a certain group you wouldn't give topiramate to. Does anyone know? I didn't know this, so I looked it up, so I wouldn't be surprised if people didn't. So you don't give it to people who could get pregnant because it's teratogenic. And propranolol, who do you not give beta blockers to?
Asthmatics.
Yeah, good. Although apparently, I read like a study which shows that there's actually hardly any clinical correlation for but it's still like traditionally taught and done. So I guess you probably wouldn't want to risk it. So cluster headaches, much rarer.
Sorry, we've got a quick question in the chat, if that's okay.
Yeah, go for it.
Someone wants to know how long the symptoms will last with a hemiplegic migraine.
Oh, so I think they last as long as a migraine does. I think it's almost the aura, but I'm not sure. That's a really interesting question. Yeah, I don't know. I guess if they came into A&E, you'd scan them anyway because you wouldn't want to like take the risk. But yeah, I think it's like as long as a migraine, or like it finishes and then the migraine ends quite soon after. But I will look that up and get back to you. So cluster headaches are like much less common. So migraines and headaches, attention headaches. Most people have had a tension headache, and everyone knows someone who gets migraines pretty much. Cluster headaches are much rarer. Men more than women, and smokers. And they're clustered. They're called cluster headaches because they cluster in like 4 to 6 week blocks. So this picture was shown to us at the Wharton Centre, and it like proper stuck with me. So these people will like go and pace up and down with the pain, whereas with a migraine, you might like go to bed. And these people tend to be seen by a neurologist just because it's a bit rarer and you want like better management. So acutely, which I think is quite interesting, you can give high flow oxygen or subcut triptans. And then prophylaxis is Rapamil. And there's some evidence to suggest giving pred, like prednisolone. But obviously you don't want to just give pred out. So I think it's started by a specialist. You wouldn't start it in like GP or anything like that. Does that make sense? Everyone with me and happy? Good. So these are another quite common one. And GP Notebook, which is like a magazine for GPs or like has loads of guidelines, says that a lot of these aren't diagnosed. So medication overuse headaches basically does what it says on the tin. You take too many medications and then you get like this rebound headache. So you effectively, to treat them, you stop the medications. And people feel pretty rough for like the first week or 2 weeks. But then after a month, you get them to come back and you see if things have got better. If they have got better, you had a medication overuse headache. If they haven't got better, something else is going on. And then you try and say, only take your headache medication when it's really bad. Does that make sense? So in terms of rare stuff, I was like, I find this stuff interesting, even though it'll never ever come up in exams. So there's some zebras, like as in when you hear hoofbeats, think horses, not zebras, which is what someone said to me. But there's Alice in Wonderland syndrome, which is like a cool kind of migraine where you get all these like visual hallucinations. So they reckon Lewis Carroll had it. So you see people as like very small. I read a case report where one woman like thought she had massive ears. Hypnic headaches are headaches that you get like wake up. It tends to be older women from sleep. And the reason I remember them is you treat them with caffeine. So you give people like a cup of coffee before bed. Exploding head syndrome is quite interesting. So people feel like a big loud sound as they're falling asleep and like their head's exploding. You just reassure these people. And it tends to go away. And then the hemicranias are pretty rare, like rarer than cluster headaches. But it's just like you either get like a continuous one or one that comes on every so often. And you treat them with indomethacin, which is like an NSAID. And then if they respond to the NSAID, then you get the diagnosis, which is quite interesting. But yeah, I thought they'd be a nice little break. So do you want a break or are you happy to keep going? Can you see what it says in the chat? Happy?
Well, people say keep going, yeah.
Keep going, sound. Okay, so I'm going to talk about hemorrhages. Oh, I gave it away. Okay, so what do all these people have in common? So does anyone know who? So obviously, who's the one with the dragon?
Amelia Clark, she had a subarachnoid, didn't she?
Yeah, good. Who's the guy in the red jumper, not in the racing thing? People? Okay, like I wouldn't recognize him necessarily. Big fan of, if you're like a big fan of like children's literature. Okay. No? So that's Roald Dahl. So he had like a traumatic brain injury. And the guy at the top, if you're into like racing and stuff. So that's Michael Schumacher, who also had like a traumatic brain injury. So I'm going to talk about hemorrhages a bit. So what can cause them and who do they happen to? So I think it was like Hippocrates or something who said, it's more important to know what sort of patient gets the disease than what sort of disease the patient has. So like I think by live by, because I don't know many diseases, but I can like, you can sometimes reason it out. So what can cause hemorrhages broadly?
Trauma, blood thinners.
Yeah, good. Anything else? So sometimes it doesn't have to be a cause. So it can just be like spontaneous, so like a rupture. So who tends to get hemorrhages?
Just to answer the previous question, someone's put Marfan.
Oh yeah, really good. Okay, so why does Marfan syndrome mean that people are more likely to have hemorrhages? You're right, like 100%. I just want you to tell me why.
It's got inflammation.
So almost. So it's to do with, so Marfan syndrome, as I understand it, is like a issue with the fibrillin, I think I read once. So basically your connective tissue doesn't fit together properly, so it's super stretchy. So you can do like cool things with your hands, but it also means that your connective tissue in your blood vessels doesn't like stay together very much, and that's super stretchy. So it's really easy for it to tear. Does that make sense? Yeah. Okay, so I'm going to talk about, so there's 3 main types of hemorrhage that come up. So there's a couple more that are like quite rare, but extradural hemorrhages. So these tend to be traumatic. So it's virtually impossible to get an extradural hemorrhage without some like element of trauma. So there's like a key phrase that's associated with these. And it's about how people, so if you fall over or you hit your head and then you have something before you collapse again. It's like a proper cryptic way of asking the question, sorry guys. Any idea? Yeah, so like a lucid interval, yeah. So that's like in the question, so when they give you images on exams, you can almost always work out the answer from the question stem if you can't read the image. So yeah, you get a lucid interval. So it's an injury normally to the pterion, which is like your temple, and it severs the middle meningeal artery or damages the middle meningeal artery. So what's the shape of this hemorrhage? So it's the epidural one, which is the same thing, just to confuse everyone. What does it look like? Literally, you don't have to use like posh words. You just say whatever it looks like.
Someone said lens.
Yeah, good. Perfect. So the way I remember it is it's like a lemon shape. So it's like almost like a circle. So it doesn't cross the suture lines of the skull. So you get injury to the pterion and it severs the middle meningeal artery. So it led to form like a lemon. So it's all the L's for this one, limited by suture lines. And it's associated with skull fractures. That doesn't have lots of L's in, but if you think about it, the pathology or the pathophysiology makes sense, because if you sever an artery, you're going to very quickly bleed compared to like a subdural where it sort of leaks out over time. So that's why these people will be all right. They'll hit the head, they'll be all right for a minute, and then they'll quite quickly deteriorate. So what do you do if this comes to A&E and you're like the F1, apart from panic?
CT head.
Yeah.
Oh, I've already done it, haven't you?
Even before the CT head.
Someone said speak to a senior.
Yeah, literally my answer for everything. So yeah, so you call for help and you do like an A to E assessment. So sometimes these, if you know what's happened, you call neurosurgery right away. If someone's decompensating in front of you, you don't need to wait for a CT head. And if it looks like a extradural hematoma, then you can call neurosurgery. So what are neurosurgery going to come and do, or what are you going to come and do if you're the neurosurgeon? So literally, you don't have to say it in like posh words. So if you've got something that's pressing on the brain, what do you probably need to do?
Decompression.
Yeah, good. So you can call neurosurgery and you do a craniotomy to evacuate the hematoma. So yeah, you effectively need to get this pressure off the brain. Does that make sense? And this is one of the, so you don't really, I don't think you need to know this for like medical school finals, but I think you probably need to know it for PACEs, like medical and surgical third nerve palsies. So with a third nerve palsy, you get down and out eye, don't you? So you get a complete third nerve palsy with this. So it's called a surgical one, because basically you need to call the surgeons to fix it. Does that make sense? Good. So this is another picture of what it looks like. So you can see this like lemon shape. Does that make sense? Or lentiform. And you can see why these things, so what's, looking at the midline, what's happened to the midline?
It's shifted.
Yeah, perfect, good. And what do you do if you see a midline shift? Is that a normal finding?
Panic.
So you like, that's like a concerning thing. And so that is sort of an indication for, you need to at least have like neurosurgery come and review this person. It's not something you can just manage. Does that make sense? So next one, subdural. So these are like very common. And these are what I think a lot of GPs, if someone comes in and they're a bit confused, it's one of those things that is worth like letting it go through your head. Like maybe this is a subdural. So acute ones happen like when people crash cars or like crash motorbikes and stuff like that. The more common type are like chronic ones, which is what you always get tested on. So it's older people and people who have like alcohol excess or alcohol issues. So does anyone know why that is? I didn't know it until like yesterday. So. So it's because the brain shrinks and the bridging veins are like pulled, so they're easier to like shear. Does that make sense? So they're like much tighter. So on CT, you get like a crescenteric shape. So basically like a crescent, and it crosses the suture lines, which is how you can tell it's different. And it's progressive confusion, which is what worries you about, or decreased GCS or a neurodeficit. So acute, if someone's, I don't know, come off their bike at like 100 miles an hour or whatever, you would give them a head CT and you might find one of these, but it doesn't necessarily mean it needs treating. So it could just, you can just get tiny little ones that can just like resorb on their own. Sometimes you need to monitor the ICP and you need to do a decompressive craniotomy. And then chronic, sometimes you need to do a burr hole decompression, but sometimes people who get these are on like warfarin or a DOAC. And it's a balance of like risk and like how many problems is it causing for them. Does that make sense? So these are the kind where like, if you're on a DOAC, that's why you need to give someone a CT head if they fall, because this could have happened to them. So there are some pictures here. So I'm a bit rubbish at reading images, but this is one that I would learn. So we're looking at CTs. Acutely, blood is white. So you can see on this acute one, all on the patient's, on this side of the image, the right side of the image, you can see all this white stuff, yeah? And it's like around the side, so just below the bone. And then the subacute, you can see it's the same sort of density as the brain, so you can't see it very well. And then the chronic, you can see this dark blood. Does that make sense? Good. So, and then subarach, which are like the, or I don't know, quite interesting ones. So someone mentioned this to us at the Walton Centre, which I hadn't like twigged before. So they're mostly traumatic, but the ones you read about are spontaneous ones. So this is where you talk about like a thunderclap headache, the worst headache of my life, meningism, decreased GCS. So they need urgent imaging. So what form of imaging would you pick?
CT head.
Yeah, good, perfect. And then when would you do an LP? Would you always do an LP, or would you never do an LP? Or sometimes.
But not always.
Okay, go on then. So whoever put not always, can you tell me why? You're right, but like why not always?
So someone else said the CT head is clear, but you're still suspicious.
Yeah, good. Yeah. So I listened to quite an interesting podcast on this a little while ago, but the thing is, if someone has a subarachnoid hemorrhage, but it's only a small one, and you don't pick it up, then the next one they have will be like the big one. So that's why we have such a like low margin of error. So what are you looking for in the LP?
Xanthochromia.
Good. So I'm sorry, I'm like quizzing this person. So what is xanthochromia, and how's it different to just like a messy LP? What do they call it? A bloody tap.
So we've got yellowy colour / bloody, yellowish colour.
Sorry. Yeah, perfect. So I didn't know this. So the first time I saw an LP was like, I don't know, last year, the year before. And you know that you take like 5 bottles or something like that. So the reason you take 5 bottles and you have to make sure that you've labeled them all correctly is if you do a bloody tap, then there'll be loads of blood in the first bottle, but it will gradually get less. Whereas if you have like a stable amount and it's xanthochromia, then you know that this person's probably had a subarach. So once you know that they've had a subarach, you do CT angiogram to try and work out where they're bleeding. And interventional radiology clip them now. So if you ever get to go to the Wharton Centre, you can watch them do it, and it's really cool. If these people are like very sick, if they have hydrocephalus, then you need to put like a shunt in. So you give nimodipine, laxatives, and bed rest. So why do you give nimodipine? Anyone know?
Got stop vessel spasm.
Yeah, good, perfect. So that's like what we're taught it is. There's not loads of evidence for that, but we still give it and it works. So no one really knows why it works, but it does work. And it helps people's like prognosis and stuff. So what do you guys think the prognosis is for subarachs? Like how many people are able to walk out of hospital fine? Ish. Anyone? No. Okay, sound. So I remember this because it's quite like an interesting. So a third die when they have their subarach, a third are disabled, and a third will walk out and be fine, which is quite interesting. Just someone mentioned Marfan's before. So like this is the type that you get with like connective tissue disorders. So other stuff like Ehlers-Danlos, adult polycystic kidney disease, which is always a link on past medicine, always, every time. And also coarctation of the aorta. And then this is the stuff you get with like AVMs, pituitary apoplexy, that sort of stuff. So rebleeding can happen. So it's about 10% of cases, and it happens in the first 24 hours, or most common in the first 12 hours, sorry. So if someone's had a subarach and they seem okay, and then they go off again, you need to get another scan because it could have changed. And that is like where it's really dangerous. So the first bleed is bad, the second bleed is worse. Does that make sense? Good. So here you can see, so it's white because it's fresh blood, and you can see it's in like the sulci in the brain. So it's like in the like brain matter. Does that make sense? So I've got some images now, and you can put in the chat what they are. So what kind of hemorrhage is this?
Subdural.
Yeah, perfect, good. And for like a bonus point, can you tell me if it's chronic or acute?
Chronic.
Perfect. Sorry, I couldn't get images without arrows. These are from Radiopedia, which is honestly like so good. So what's this one?
Subarach.
Good. This one.
Epidural.
Perfect. This one.
We've got extradural.
Mm-hmm. Anything else?
Lentiform.
Yeah, good. So that's like a description of the epidural one. Anything else on the other side of the brain?
And then someone said epidural on the other side.
So epidural on one side, and has anyone mentioned the right-hand side of the image?
So someone just said subdural and epidural.
Yeah, good. So what's happened to this person? We don't know, but what can you guess has happened?
Trauma.
Yeah, good. So they've had some kind of high impact injury. Does that make sense? So now the plan is to try and split these into breakout rooms. So I've got a couple of cases. So Catherine's like on it. So we've been practicing. So we've got a couple of cases that I'm just going to give you 5 minutes to go through. So I'm going to give everyone, I'll put these in the chat, I think. Let me see if I can do that. Someone from the first, or anyone really. So she comes to a GP complaining of a headache. So what features might concern you in the history?
The fact that she's having a progressive headache that's getting worse.
Good.
Visual disturbances.
Perfect. Yeah, good. What other questions would you like to ask her? That's a bit of a dud question, to be honest. But yeah, you just like take proper history into an examination. So what do you think is going on with this girl, or this woman, sorry?
We discussed that it could be a migraine, but not too sure.
Yeah? Anything else? So she's got some features of raised ICP, hasn't she? So when she coughs, she's getting black spots. So that's due to the papilledema. So what is a condition that can cause raised ICP in young women?
So someone said idiopathic intracranial hypertension.
Yeah, good, perfect. So you might not have heard of this because we only heard of it, I think someone did a case on it once and we understood it. So effectively, it's in generally young, overweight women. And it used to be called benign intracranial hypertension, but they got rid of that name because it's not benign, because like high pressure in your head's pretty bad for you. So how do you think you manage this condition? Sorry, you can see like my cat in the back. She's just woken up. So how do you manage this condition? So literally, if you have high pressure anywhere, what could you do to get rid of some of the pressure?
Your antihypertensive shunt.
So good, you could put in a VP shunt. So you can give antihypertensives for high blood pressure, but it's quite difficult to get anything that could affect like the intracranial pressure. So you can give, I think it's like carbonic anhydrase. I didn't write that down, but you can give something like that. What's like a lifestyle thing that these people could do? So if she's like very overweight and that is one of the things that's causing her hypertension, her intracranial hypertension.
We've got reduced salt and weight loss.
Yeah, good. So weight loss, that's like a really important one. And you can also give them therapeutic lumbar punctures. So effectively I don't know how often, but every so often they come in and they have a lumbar puncture and it just takes off some of the fluid. Does that make sense? So there's certain medications that you should avoid. I wouldn't expect anyone to know this, but if you do, I'll be very impressed. What's one with, go on, does someone have something? What's one with overweight women or women with high blood pressure? What is not a good thing to give them for contraception?
People are saying oral contraceptives.
Yeah, good. So like the combined pill is like not good. A couple of other things that I guess would make sense are stuff like steroids, because that increases like your metabolic risk. Tetracyclines, vitamin A, lithium. You wouldn't necessarily know that, but yeah, so the main thing is like the oral contraceptive pill. Does that make sense? So case number 2, a 62-year-old man with worsening headaches. He's lost a bit of weight and he's been being sick like spontaneously. So why might that concern you? Why? Go on.
So people are saying raised intracranial pressure, brain neoplasia, red flag for malignancy, overthinking.
Yeah, good. Yeah, perfect. So if he has a malignancy, is it most likely to be primary or secondary?
Secondary.
Yeah, good. So like most brain tumors are secondary. So if it's secondary, so basically what cancers metastasize to the brain? So give me any.
Prostate.
Let me see what I've written down. 2 seconds.
We've got
Yeah, I think so.
lung,
Anything else?
so lung, breast, testicular.
Yeah, good. So I've got lung, breast, kidney, melanoma, colon. So I'm sure the prostate cancer can go to the brain. But I think also a thing that I got confused with is, you know, like the lead kettle thing. So like PBKTL, which is stuff that metastasizes to bone. So to brain, if you think about it, it's a lot of stuff that's like in the upper body. So it's lungs, breast, kidney, melanoma, and then I guess colon's the odd one out. But does that make sense? So what type of imaging would you do for him?
MRI.
Yeah, good. I'm going to be mean and ask you why.
Better for tissues.
Yeah, perfect. And then what medication could, obviously you wouldn't just start this in GP, but like what medication could reduce his nausea and vomiting if he's got raised ICP?
Ondansetron.
Yeah, that's good for like chemical nausea, isn't it?
And then someone else says cyclizine, levomepromazine.
So levo would be good, but it sedates him quite a lot. So there's another medication that's really good for like, it's not a traditional antiemetic, but it's good for like inflammation. And then when you reduce the ICP, you reduce the nausea and vomiting. Good for
Something like
edema.
Dexa, which I assume is dexamethasone.
Yeah, Dex. Yeah, perfect. So my understanding is that Dex is good because it doesn't just hide the cause, it like reduces the inflammation. So that's like often used. Levo is a good like all-round antiemetic, but as far as I remember, it is like a couple of months since I did my finals. You only tend to use it when people are like entering the last days of life, because it's quite sedating. Does that make sense? So, and then the next case, so he has the worst headache of his life, and then lost consciousness. So what are your immediate management steps?
Just as a side note, I've just noticed that you accidentally copied case 2 twice. So if you guys can still do
Oh, sorry.
it, we'll be doubly impressed. But we've already got people saying A to E.
Yeah, perfect. Yeah. So that's like what you want to say. What are risk factors for this condition? Like any risk factors for like subarach?
So we've got APKD. So I think that's adult polycystic kidney disease.
Yeah, good. Yeah, but
and then someone said worst headache, hitting the back of the head.
Yeah, good. So other risk factors would be like all the like connective tissue diseases and stuff like that. So how would you manage this condition? Or who would you call?
Someone said drain blood, bed rest, nimodipine.
Perfect. Yeah. So you call the neurosurgeon, and they do all the like, craniotomy and stuff like that, and then you look after them on the ward. So what's his prognosis like, and what factors would affect prognosis? So I haven't said this, but you can sort of guess like what factors affect a prognosis or something. So
Comorbidities.
yeah, good. So is someone going to do better if they come in and they're complaining of the worst headache of their life, but they're still talking, or someone comes in with a GCS of 4? Which one of those will do better? So it'd be like the second, the one who had like a normal GCS or like a just slightly decreased GCS. Another thing is like if you have a really high blood pressure on admission, that's pretty bad. And age. So the older you get, the worse the prognosis gets. So has anyone got any questions? Thank you all for sticking around. I'm sorry I put you in breakout rooms. It's been a bit mean. Is that everything?
Well, thank you very much for that, Cora, and thank you everyone for coming. Just before you go, I put a little link to a bit of a feedback survey, which should take you less than a minute, which would be really helpful for us to make these teaching even better for you and give Cora some great feedback to help with her own teaching. So yeah, thank you again for coming, and we'll be back again next week. I believe it's renal next week, so fun kidney things. But yeah, thank you very much for coming. I hope you guys enjoyed it.
Thank you.